So we go ahead. So we are having Dr. Simona and Dr. Walid and two guest faculty also. Dr. Simona is a pediatric urology from Regina Margherita, Turin, Italy, and Dr. Walid is from Wisconsin University. And I remember Dr. Walid because most of the residents, they are talking about his TVSS score, and it has become almost for synonymous with his name, and this has been modified subsequently by many authors in many countries. We welcome you both on this podium.
Thank you.
So Amir, this is the history of the baby.
Yes.
Yes.
Yes, sir. This 1.5-year-old child presented. This child presented with the chief complaints in our OPG with a recurrent febrile UTI from last 6 months and with a history of a failure to thrive. The child had achieved appropriate developmental milestone for their age. In the family history, he has a healthy 5-year sister with no notable medical history. So can you change the slides?
Yes.
This child exhibited bowel movements which were infrequent and they were occurring every alternate day. They were characterized by a lumpy and sausage-like stool, which we can rate on Bristol stool scale as 4. On physical examination, the weight of the child was 9 kg and height was 78 centimeter. The child appeared well and was playful, and the vitals were normal, and rest of the physical finding, including genitals, were unremarkable, except that the external genital were uncircumscribed.
So what do you think?
Looking at this age,
yes, going through this history, what do you think in your mind? It's a 1.5-year-old baby.
Yes, sir.
With febrile recurrent UTI.
Sir, I think the history, according to the history, the hydronephrosis or hydroureter nephrosis, these two differentials comes to my mind. In hydroureter nephrosis, it may be due to megaureter, maybe refluxing or non-refluxing. Whereas if it's an hydronephrosis, it may be with a pelvic ureteric junction obstruction. These two frequent presentations are we see in this age group.
So one you told this could be the dilatation of upper tract along with dilatation of the ureter, hydronephrosis, or there may be a hydronephrosis, or do you think there may be some features of sensitive or bladder outlet obstruction, the possibility of posterothal valve?
Yes, there may be history of it, but the child presentation of the child doesn't give such a indication to it. And but hydroureter nephrosis definitely bilateral. The presentation with bilateral hydroureter nephrosis generally in this age group or in the male child definitely points towards these posterothal valve or any bladder outlet obstruction.
As such, the family does not give, or the caregiver does not give the history of any lower urinary tract dysfunction.
Yes,
the
sir.
stream is okay, and there's no
Stream is okay.
Yes.
No, sir. There's no history of any such complaints of which suggestive of any bladder outlet obstruction or anything related to it.
So you have given two possibilities. One is of hydronephrosis, and of course the megaureter, which could be refluxing and non-refluxing. Only the investigation will solve this, and a possibility of hydronephrosis, and I believe in terms of uretropelvic junction obstruction. Do you want
Yes,
to add any other differential to this?
There may be a bladder diverticulum as well in some cases, or we can go for we will go in the direction of bladder outlet obstruction, as you have already told, like posterothal valve and
but the baby does not give any yes, but the family does not give any history of urinary tract dysfunction.
Another differential which is common in this, not so common in this age group, it because the child is not toilet trained, is bladder bowel dysfunction.
Okay. So Dr.
Yes.
Simona or Dr. Walid, do you have any other suggestion to this so far?
Yeah, go ahead, Simona, please.
No. I think that even when you see hydronephrosis, at least in my experience, you should, without a dilatation of the ureter, in a male child with febrile UTI, you should still think more of a reflux than of a UPJ obstruction, at least because UPJ obstruction rarely gives recurrent pyelonephritis and failure to thrive, especially if it's I think it's a different, it's a rare presentation. And I think that what you have most to focus also is the bladder. So bladder dysfunction, or it's a male, so ureterocele is rare, but could be another possibility, and any kind of bladder outlet obstruction.
Dr. Walid.
Yeah, I will look at this patient from a different perspective. I think, I mean, for the residents, I always try to explain to them that 50% of the patients with possible urinary tract infections don't have urological anomaly, obviously. So that's something that they need to remember at all times. But in this particular patient, even if the ultrasound is completely normal, I still think, as Simona said, there might be a history of reflux, or there might be something suggestive of reflux. This patient is uncircumcised. This may increase a bit the chance of urinary tract infection. And in terms of differential diagnosis, I would still think that reflux might be the first on my list. Now, when it comes to megaureter, maybe I missed what's the size of the ureter on the ultrasound, but I would like to look at multiple ultrasounds to make sure that I can actually identify the dilation of the ureter in terms of numbers. I think 1 centimeter is different than 1.5 centimeter. But I still would, differential diagnosis will be reflux.
Okay. Because as such, the prevalence is more as compared to other possibilities for reflux in this age.
I'm sorry?
The prevalence of reflux in the setting of a febrile UTI is more rather than with UPJ obstruction.
Yeah.
Yes.
For febrile UTI, yes.
Yes, sir. So, yes, Dr. Sardar and Dr. Mohan, do you have any other thought, sir?
Carry on. Do we know the ultrasound? We didn't do the ultrasound yet, did we?
No.
Yes, we will be coming subsequently, yes, for that.
Yeah, I mean, in our case, we would not even start a differential diagnosis discussion without the ultrasound. Because what we do in our clinic now, whenever we examine the patient, we do the ultrasound by ourselves. So it's a very simple, non-invasive tool, and you can exclude many of the differential diagnosis by just looking at the ultrasound, like UPJ. You don't even need to mention that with the ultrasound. I mean, if there is no hydronephrosis in the upper tract, you don't need to even think about the UPJ. But ultrasound examination should be done properly, especially in 2 stages, when the bladder is full and then after the bladder is empty. So you can look at how the
Sound went off.
Okay.
Sorry,
So,
I can't hear any longer.
So, yes,
Do you hear now?
yes. Yes. You are back now, Dr. Anil, now.
There's an echo. I think that's why they stopped. I mean, we do the ultrasound when the bladder is full. And if you see upper tract dilatation when the bladder is full, there is an indirect sign that there may be reflux. And after the bladder is emptied, if the dilatation goes away, and this is another indirect sign that there may be reflux. You can also check the bladder wall, if the bladder wall is thickened or not, to exclude the presence of any inferior cycle obstruction. And you can also look at the trabeculation of the bladder wall, bring the time that the bladder is full and maybe judge about any infravesical obstruction there too. So ultrasound is so useful in by any means to exclude many of the differential diagnosis components. And in my understanding, reflux would be number one in the differential diagnosis, but all the others can easily be excluded with ultrasound examination at this point.
Okay.
We do it ourselves. I think this has become standard in many centers around Europe now. In every outpatient department for pediatric urology, most physicians do use ultrasounds for the initial examination.
I agree with this because of the volume load in the Indian patients. So by clinicians, they usually keep themselves reserved for this history and the clinical examination. And usually the sonography we sort subsequently from the radiology department. But I have seen in many centers in Europe, in even in US also, the clinicians, they do the ultrasonography themselves. Dr. Mohan, your thoughts, sir?
Mohan is just out for a while. So,
Okay.
meanwhile.
So we are back to this.
Yes.
Amir, what next, Amir? What do you want now to summarize your differential diagnosis?
We will go for urine analysis.
Okay, you want some more test.
Yes, sir.
So these are the serum panel.
Okay.
Okay. Yes.
So yes,
You do not find anything unusual in this. Okay.
nothing unusual, sir.
Yes.
Everything was within normal.
Yes, this is the urine, what you wish.
Yes, sir. So the urine analysis showed the leukocyte esterase was positive and nitrites was also positive. So it was an urinary tract infection. And upon culture sensitivity, we found it as an E. coli, which was definitely pan sensitive as a child was not having any history of any antibiotic use earlier.
Okay. So you had a report at your hand ready that the child is running a fever secondary to urinary tract infections. Now what next?
Now, these findings and clinical history is very suggestive that we should go for an imaging. And first will be the choice will be ultrasound and non-invasive imaging.
Okay, this is the ultrasonography.
Yes, sir. So there's in this ultrasound, this longitudinal ultrasound shows a left kidney with hydronephrosis, hydroureteronephrosis, and the parenchyma is relatively normal. So, and the dilatation of the collecting system extends from the renal pelvis to the minor calyxes, and possibly SUV grade 3 hydroureteronephrosis can be attributed to it.
SFU grade 3. Okay.
Yes, sir.
Are you happy with the bladder? Because I think this is a bladder which is partially filled. Yes.
Yes, sir.
Not yes. This is not either empty nor full. So, Dr. Simona, you are happy with this ultrasonography, or you want something more?
I didn't see the longitudinal diameter of the kidneys. I don't know whether the kidneys is smaller. They are symmetrical. I see nicely the figures behind the bladder. The bladder looks fine. It's half filled, but it's not thickened. You don't see trabeculation, and I think it's quite okay. I mean, it's adequate as far as you might need. But I would like to have the longitudinal diameter of the kidney.
Right.
Yes. There are two things which probably I would like in this particular ultrasound. One is that the lower ureter.
Yeah, your voice is echoing. I think there's two sound systems which are working.
Yeah. Is it okay now?
Now, yes, very nice.
Okay. Now, I would definitely like to know the status of the ureter and the lower ureters here, which the bladder should be fairly full to make a diagnosis of it.
So
and then the upper ureter should also have been shown in that. We are just seeing the pelvis. We're not seeing the ureter. And if I presume that the ureter is not there, I think we are looking at a different diagnosis. But I think the ureter should be properly shown.
Yes.
One thing.
The ureter is behind the bladder.
Right. So I am giving
I
you
think,
purposely. Yes.
yeah,
We
I
purposely
think
did not mention the reports. Yes. So retrovesical ureteric diameter was 8 millimeter and the pelvic epi diameter was 1.5 millimeter.
the important thing that this is to be taken as a full bladder. See the bladder wall thickness, and along with that, when you are doing a good ultrasound, the posterior urethra should be seen,
Okay.
and that is visible with the ultrasound.
Okay. So Dr. Walid,
Yeah, but
please comment on ultrasonography.
in a child of a year and a half, it's sometimes you have to do several observation just to find out the full bladder, and sometimes you just pick an empty bladder. So it's in a child of a year and a half, sometimes you have to stick to what you can have.
Okay.
Yeah, the images are suboptimal, to tell you the truth. I would like to see more images. I know that you can see hydronephrosis, but I don't like to judge an ultrasound based on only 2 images. And again, I only try to explain things from a resident's perspective, because I think if you can judge what the hydronephrosis here, you can miss a lot of images between the kidney and the bladder. And finally, I just want to go back to Amir when he asked for urine analysis. I think it's important to really comment on how the urine was collected in such a patient. So that's another thing that may need to be highlighted at one point, whether it was catheter or a back collection.
Yes. So Amir, this was a catheter sample, or this was a back collection, or this was suprapubic aspiration? Or this
Sir,
is a
this was catheterized sample because the patient was not toilet trained, and they were not contaminated, all the cultures, and they were in this age group. So we did a catheterized sample.
Okay. So what do you need further to narrow down your differential diagnosis?
Since the clinical history is very suggestive of febrile UTI, so we will go for rule out hydroureteronephrosis.
So far we have a ready radiological evidence is that there is a febrile UTI with proven culture positive with left hydroureteronephrosis.
Yes, sir.
So how do you confirm that this is a mega ureter or this refluxing or non-refluxing? So,
sir, we will go for VCUG.
VCUG.
Yes, sir. Voiding cystourethrogram, sir.
Okay. So you want a VCUG, okay?
Yes, sir.
So
as the imaging is registered.
Okay.
Yes, sir. This VCG is performed in the widening phase, and the bladder wall appears to be smooth, and the urethra is normal, and there is evidence of contrast in the left ureter. It's suggestive of reflux of SUV grade 3rd. Abdomen, there is a typical motile appearance due to solid feculent matter. Yes, sir. So I can say that.
Sorry.
Yes, Simona, please go ahead.
May I ask, I know that for this reason we don't see more images, but may I ask how does the bladder, when the reflux appears during the bladder filling and how it is like? I mean, if it's just first grade during the bladder filling, it appears at the early bladder filling, at the end of bladder filling, and there is, in this projection, if there was any small diverticula, we can't see that. So just describe a bit better, a bit more completely the VCUG.
Correct. Because this is the one static film, ideally there would have been a right and left lateral projections also, just to find out the diverticulum also. And this reflux should also be whether it is at the time of low pressure reflux or high pressure reflux, whether the the baby has reflux at the time just filling or at the time of voiding. So Dr. Walid.
Yeah, I would like to see a scout film for sure. I always think that I need to see the spine. I agree that the BCUG does need more cinematography to confirm when the reflux is happening upon filling or emptying, because that has an implication on resolution. And otherwise, I think I'm quite happy with the urethra and I'm happy with the bladder. And if I combine the ultrasound imaging with the VCUG, I think we have a diagnosis here of reflux.
Okay. So, Dr. Sardar, do you have any other thought, or what else should we see in VCUG?
I would only echo what others have said. Reflux is a dynamic disease, and you need to have the whole series of filling, emptying, and everything to understand its nature better. It's happening in the filling or later in voiding. And the same is true for the ultrasound. We don't like to look at the ultrasound images. We need to look at it the whole way ourselves, or at least more information on the ultrasound rather than looking at a couple of images. What sort of concerns me is what I saw on the ultrasound, the degree of dilatation does not match the reflux here. So this is a bit, I'm not sure if it looks like to me that this VCG does not belong to that ultrasound. Am I mistaken or not? Or is it just a visual thing to me? Because what I saw in the ultrasound was the dilatation, the degree of dilatation was much higher compared to the degree of dilatation in that pelvis. And also it looked like a mega ureter somewhat. Here what we see is not a dilated ureter, it's just grade 2-3 reflux. What we saw was on the ultrasound was much higher in terms of dilatation. So it's important to look at all the pictures complete to make a judgment. But at the end of the day, like Walid said, the bladder looks fine, the urethra looks fine, so there's no infravesical obstruction. There's low-grade reflux, basically. But again, I'm repeating myself that this is not a complete evaluation, either by ultrasound or the VCG to judge.
Correct. I fully agree. Yes. So, Amir, you have so far you have the diagnosis of grade 2 vesicular reflux on left side.
Grade 3.
So how to move forward now?
I would like to add one more imaging, that is nuclear scintigraphy, like DMSA scan, which to see the how many scar and is there any evidence of any scar due to any previous pyelonephritis. So I would like to order an DMSA scan.
Since the baby had a febrile UTI, I want to see not only the scarring, but also the differential function of this kidney also.
Yes, sir.
Yes. So this is the scan.
No, this is
doesn't
look like
in the scan, the upper pole of the left kidney showing a photopenic area suggestive of any scar, and the split function of the left kidney is 36%. So definitely it had a episode of pyelonephritis earlier.
Usually no, it's probably 40-60, 44-60, 45-55.
So what should be the ideal time of a DMSA scan? Is that what the system is seen on ultrasonography and VCUG? It may not be corroborating with the finding. Or yes, Dr. Simona.
I would be interested to know, when was the last febrile UTI before the scan? And I wanted to challenge, and to ask the other speaker whether in a second grade reflux, the one that we saw on the VCG before, if they would always do a DMSA scan, or because does it change our approach, and does it change our indication to treatment to do a scan, a DMSA scan, in a second grade reflux in this patient?
So, Dr. Walid, I would just ask if the scan is done too early, can it underestimate the function of the affected kidney?
Yeah, I mean, I'm not sure I can comment on the function of the kidney. This kidney doesn't look like it's such a low function. I mean, it really doesn't look like a 36%, but irrespective, if I want to go back to the question, Dr. Ansari, I think the timing is so important. If it's done within 6 weeks to 6 months, it may not be reflective of a scar. It may be reflective of pyelonephritic changes.
Yes.
To answer Simona's question regarding DMSA, it's such a crucial question, and I thank you for pointing that out, because I personally consider DMSA is more for prognosis to the parents. Like for boys, I don't tend to do too much DMSA if there is a history of reflux, but irrespective, I would say timing of the DMSA is important, and if it's done too early, it might be pyelonephritic changes. I think if a patient keeps on having recurrent infections and I need to make a decision for intervention, I may consider doing a DMSA just to guarantee to the family that it's a matter of why do we need to do it. But if it's a completely different scenario, like a female, I may have a lower threshold to do DMSA. I hope I answered the question.
Dr. Sardar.
I completely agree with Walid. I mean, of course, the timing is very, very important. This DMSA will not change your decision. It will just serve as a baseline study for future comparison in case that there will be recurrent urinary tract infections. And it is more useful for girls, of course. And I'm not sure if this is a scar or just a photopenic area soon after a pyelonephritic, acute pyelonephritis. So that doesn't tell me much at the moment, either to make the decision for surgery or for future prognosis. And I also believe that 3664 does not represent what I see as image.
Yes.
I would think it's 45 to 55, something around that. But there's certainly a photopenic area on the left side in the upper cortical area. And it could be a scar, or it could be a photopenic area just a couple weeks after the pyelonephritis, and it will heal and normal parenchyma will fill in there. So it doesn't tell me much at the moment, and it will not change my decision-making at the moment.
Correct. Dr. Anil, you sometime had work on scar on the kidney post-reflux. So
Yeah.
I just pose a question to you.
Yeah.
Two types of scar, which is these two types of scan practice is done in India. One early DMSA scan after the this febrile UTI, and secondly, it is done after 3 months.
Yes,
that's it.
Yes. What is your question?
They say in India, usually what happens, many of the clinicians, after acute UTI, within a week, a DMSA scan is advised. So can it give false impression of dysfunction?
Yeah. So, see, generally, if it is a first infection, right?
Yes.
And we have detected the VUR, what we practice is we generally do after 4 to 6 months first scan, because most probably we are not going to operate so quickly that patient. So there is no point of right now at that time doing anything. But what happened in the peripheral practice, the most of the patient comes with the history of 3-4 febrile events where urinary tract infection is not detected prior. So on third or fourth time, pediatricians either he detect or he refer to us, we detect the febrile pyelonephritis. And at that time, I do practice the acute phase DMS scan. Right now, the DMS scan which you have provided, there you can see this polar lesion, upper polar, and there is a deficient uptake or absent uptake with the loss of little bit of contour. Which here I use the terminology of scar, because the scar is healing process, and there is a evidence of febrile UTI and then pyelonephritis and then the healing. So the scar, we should use the terminology for this kind of lesion. If I have a photopenic area without loss of contour, I say that it is representative of acute pyelonephritis, which we do see in a scan which we do while the acute infection is still going on, or within 2-3 weeks of the acute infection. And third thing is that what we see in a congenital nephropathy, reflux nephropathy, is that we don't even see the history of urinary tract infection. It is just evaluated for the antenatal hydronephrosis postnatally, where we see high-grade reflux, and then we do the DMSA scan. We see the global reduction of the volume of the kidney. That is not representative of a scar, or we should not avoid. We should avoid term using the scar for that. Rather than we can say that it is a hypoplastic or dysplastic kidney associated with the reflux, and the terminology either congenital lesions, or we can say congenital reflux nephropathy on the scan. So my aim is to give a right nomenclature, or you can say right names to the lesions which we have seen in DMSA scan of a reflux patient, rather than using only single terminology scar for whatever we see in the DMSA scan in presence of reflux.
I have a question to Anand. Do you think that photopenic area will heal in the future or not?
Yeah. So
is there a possibility for it to disappear?
So in this scan, I see little bit of deficiency in the contour. So I feel that this is not exactly representing the. Suppose if it is only a acute photopenic area, means you can say it less uptake without loss of contour, then still we see the upper border of the kidney. I am not seeing upper border of the kidney there. So I feel that this, I don't know when it is done. Probably if it is done after 2 to 3 months or 4 months, it is a representative of the already loss of contour. And in that case, it is a scar. But many of the cases I've seen, the photopenic area disappears without producing the scar.
Yeah, that's the point. I mean, we don't exactly know how long after that DMSA, after the infection that DMSA is. I cannot tell you that this is a permanent, irreversible photopenic area.
Yeah, when it loses the contour, then we have to say not exactly. This is very small lesion.
That's a very small contour.
Yeah.
Because what Anil is mentioning is that you see the configuration of the kidney changes in the upper pole quite apparently. This is just a small area.
So it's very.
So I have a higher expectation that this will heal in time.
So this is
if
just
it is done in an early phase, if it is done, we can say that it is still photopenic area which can disappear. But if it is done after 4 to 6 months of the acute infection without having a repeated episodes, then probably this may stay.
And this is also important that this is focal. It's a focal area. If it's diffuse, it's more dysplasia. But when you see some focal area from the cortical area, this is mainly due to infection. Either early after infection, so that they have a chance to heal, or in the long run, they remain as a scar. But these are normal kidneys. They're not dysplastic. We can say that.
Perfect. So this kidney size is perfect. This lesions is polar, focal, and very much representative of the infection or post-infection sequelae.
Exactly.
So I agree.
But this distinction is very important, and for residents, it's very important to remember this distinction, because this can help in the deciding the treatment as well as the prognostication, that differentiating from the congenital lesion and from the acquired lesions.
So I just to summarize it, because if you see the fate of the DMSA done in the acute phase, literature suggests 2/3 to nearly 60 to 80% of these photopenic areas over a period of time settle. So if it has been done within the acute phase, that is within 3 months. So there is a possibility that may be one reason why it has been reported 36%, and there is a photopenic area. This may be a resolving part of the pyelonephritis. Now it is limited to 1 lobe. So, okay. So Amir, I just wonder, why did you ask first VCUG and then renal scan? Why didn't you ask the first DMSA scan, then VCUG? If you had a higher card of this differential on vesicular reflux.
Sir, we basically have two approaches. There is top down and bottoms up. So we went from a bottoms up approach, but yes, sir.
So this is your institutional policy which you have been
Yes, sir.
following. This I think
Yes,
Dr.
sir.
Rakesh Ranjan, kindly please you mute yourself. Dr. Rakesh Ranjan, kindly mute yourself. Yes, please.
I'm sorry, boss. Can
Yes.
we take this? Or no? I think when we are looking at a top-down or bottom-up approach, I think it is the ultrasound which probably decides whether we should go which way.
Yeah.
You have a child with an acute pyelonephritis, diagnosed acute pyelonephritis. The ultrasound is absolutely normal. I think over a period of time, things are doing well. The issue comes in whether you really want to do an VCUG or not. And a normal ultrasound and a normal tract, I wouldn't say that it is definite that there won't be a reflux, but where there is no scar on a DMSA over a period of 3 to 6, done around 3 months to 6 months, the chance of having reflux is around 17 to 18%. But if you have a scar, it jumps to 75%. So probably the whole world is going away as far away as possible from doing a VCUG. So that's where I think the bottoms up approach comes up, the top down approach comes. But if there is an anomaly on ultrasound, I think it's a VCUG probably which comes up first before we go ahead and do the DMSA.
I'm perfectly agree with the opinion of Malik. What I feel the importance of the top down is that we can curtail the number of VCUG, as well as when we do VCUG, probably if there is a reason, if we do VCUG, it is possible that we are going to pick up the significant, clinically relevant or significant reflux. So best advantage of top down is that one is that we can curtail the number of VCUG if the DMSA scan is normal or near normal. And second thing, even if we do VCUG, if there is a reason, what we are going to pick up is the clinically significant. So if the facilities are available, then definitely I think that is the way go forward.
We should also be aware that
if the sonography is showing some changes, definitely.
One episode of acute pyelonephritis, the rate of scar formation is around
Just
6%.
6%.
There were 4 episodes of pyelonephritis. The rate of scar formation comes to 48 to 60%, 50%. So I think this tells us that where we should do a top-down and a bottom-up approach.
Yeah, I would repeat the same. I think this patient is got to go to a VCUG because of the dilatation on one side. So because the ultrasound didn't rule out the presence of reflux. Since we've not been able to do that with the ultrasound, we need to see if there's reflux or not by VCUG. And there are already 4 febrile urinary tract infections. I would not even think of doing the top-down approach in this case. I would go ahead with the VCUG because there's already evidence that there is dilatation on one side.
And 4 episodes.
Okay, let us hear from, let us hear. Before I go to Dr. Simona, Dr. Wali, Amir, what are your thoughts? Why did you opt that? What is the justification for both the approaches? How does the literature support top down and bottom up?
Sir, the literature for now, the top-down concept, we have to understand that the concept is based on the notion that only clinically relevant reflux with potential to cause renal injury is worth of uncovering. And the critical assumption is that the VUR in the absence of scintigraphic renal abnormality is unlikely to cause future renal damage. So as a part of initial workup, only a DMSA scan is obtained shortly after febrile UTI and reserving a VCG for patient with abnormal finding on renal scan. And if we go in the terms of the studies, I would like to quote 2 studies. One is a Hansen, Dr. Hansen et al. He did a retrospective analysis and reviewed 300 children. They were younger than 2 years of age who had undergone evaluation 3 months of their first UTI. In this study, 82% of these infections were febrile and DMSA was abnormal in 51%. So, and it was found that 26% of the children, of whom 53% had abnormal DMSA scan. So we can say that in that study, only 7 cases were missed out of the 303 patients. And out of that 7, grade 3 to 5 UR were found in in 6 patients, and one had only scarring.
Okay.
Whereas
So
if you
let me summarize. Amir, let me summarize because I know that we have to move forward. So the conventional approach, which most of the centers so far have been following, is what has been advised by American Academy of Pediatrics, and this is the Sweden approach, which has been the kidney and then to go to bladder. So these are the 2 studies which you quoted is from the Sweden. One is the Sweden, and second is Dr. Preda. And you rightly mentioned that the missed VUR was to the tune of 2 to 2.5%. And majority of them, these refluxes were also harmless. So Dr. Simona, what is your practice? So you go first.
My practice is to go to the traditional bottom up. We do VCUG first, and then we do DMSA scan if we think that there are scarring, or if he has a smaller kidney, or if we need the DMSA to decide our approach. I totally agree with my predecessor, with Dr. Tagul. I was just wondering if in the case that we presented, if we had a top-down approach, let's say that a patient with 4 previous acute pyelonephritis and dilatation on the left side, we did DMSA, and DMSA showed no scar. Okay, hypothesis. You wouldn't do a cystogram. I think in such a case, we would a cystogram anyway. So in this case, probably the top-down approach would not be appropriate, as Dr. Tagul said. Do you agree with that?
Yeah,
Even though
I
we
agree with
didn't have-
Simona, totally.
I
just want to, yes, go ahead. Sorry.
So it might be I mean, we still are stuck to the traditional bottom-up approach. BCG first, and then the MSI.
Professor Ansari,
Please go ahead, sir.
I think for the residents you tell that cardinal signs, these are the cardinal signs where one should have to go to top-up approach. Means there the first episode, there are no scarring evidence on the ultrasound, and ureteral dilatation is not massive.
Yeah.
Or not there.
Or not there at all. So these cardinal signs, if they have, then one has to go for the top-up approach. Otherwise, our conventional is good.
And I also want to say that those 2 articles are coming from pediatric clinics. They're not urologists. So they deal with a different group of patients. And
Yes.
none of them have, I mean, I know those 2 articles very well. None of them have gone through, there is no data about the ultrasound. We don't know what the ultrasound shows in those cases. If you look at the similar data from Washington, where Dr. Majid was doing the DMSAs, the number of abnormal DMSA after the first UTI is much higher, and normal DMSA is much less. So it's a different patient group. So in our group of patients, we usually receive higher grades of reflux, and they have already gone through a number of febrile urinary tract infections. And we're not in a position to really to judge whether reflux is there or not. Most often, we know that there is a problem with those patients. We need to diagnose with a proper VCUG. But this is a much milder group of patients. And if you look at the information of those papers, the average grade of those patients is very low. So these are low-grade refluxers. And this is the reason why you have many normal DMSAs after febrile urinary tract infection, because they are not clinically important refluxes. Most of our patients in urology clinics are clinically important reflux patients, and going through DMSA will not save as much patients as in those studies from VCG. We would do VCG to many of them anyhow.
Correct. So, Amir, now you have a diagnosis. It is a grade 2 reflux on the left side. So, just for the benefit of all these participants and the postgraduates and the fellows, you just tell us who all should be evaluated. They should know when should we evaluate, because all these things, all this investigation, the team, they need money, they need time, and they cause a lot of workload on the hospitals. You tell us who all should be evaluated when a baby comes.
Yes, sir. In this, who should be evaluated is different for different guidelines have been generated. For example, American Pediatric Association, NICE guideline in UK, and European Association, they are quite different in their age group. So, Pediatric Association gave guideline that diagnosis and management of febrile UTI in child in 2 months to 24 months of age. Whereas according to NICE guideline, they say the infant younger than 6 months of age and who are having febrile UTIs or atypical UTI. Whereas in 6 months to 3 years, they suggest a febrile history or there is any imaging suggestive of any hydronephrosis. So, and in the approach by the European Association is different. The age group is different. For example, more than 1 year of female or more than one year of male having a recurrent febrile UTI. So the age group, age dependent criteria is there in both NICE and European guidelines. Yes, sir.
So yes, so this is what has been told. A part of it is that there is some little differences, but there is a lot of overlap between all, whether it is an American guidelines or UK or it is a European guidelines. I just wanted to have opinion of Dr. Walid. What is your practice?
That's possibly a very tough question. To tell you the truth, I am very individualistic when it comes to requesting top-down or bottom-up approach and using even C-reactive proteins in blood work. I think it all depends on the particular presentation of the patient, and I would say I actually trust a lot of the publications, but I think it's completely true. Your population in your publication does make a difference on how you want to comment on it. So for instance, when I see a family in Wisconsin, let's say, I ask very specific questions in terms of how aggressive I want to be. So for instance, if the family live too far from a medical center, if the family has, it's their first child, this is not their first infection, I will go straight to the VCUG. I just want to confirm that I'm not missing on anything. If the family is coming from close by and there is no reason for us to really rule in or rule out reflux, but the family is worried about the impact of the infections on their child, I may request a DMSA. But if I want to be more specific and I want to answer your question without confusing the trainees, I actually do believe that the paper that was published in 2012 by Nader Sheikh from Pittsburgh, where he investigated the top-down, bottom-up approach, showed that the DMSA first or C-reactive first is suboptimal compared to requesting a VCUG from the get-go. So if you have an interest to know how you want to help that child and they are needing attention for recurrent infections, I will just go for a VCUG and I will just make sure that I rule out the reflux. But it's really, I want to emphasize that I tend to believe guidelines, and that's why this slide is so much telling, because every country, every state, every place does have a different population. So it would be hard to take a blanket and apply it on everyone. So that's why you have AAP, you have NICE, they have the SPU. But I tend to do more VCUGs if I want to rule out reflux than a DMSA, except in certain situations.
Okay, thank you. So, Dr. Simona, do you have different practice or evaluation? Yes.
As Walid said, now we are going toward a more individualized approach. I remember when I was young, according to a PILA guidelines, if a child had a single febrile UTI infection, no matter what the ultrasonography was like, he would have a VCUG. And after at long-term follow-up, it turned out that most children and infants with a single febrile UTI in the first 3 months of life and the normal kidneys, they will not have reflux on the VCUG. So probably we have to carefully select our patient, and we have to reduce the number of VCUG, of useless VCUG that we do. So I think that the importance of the ultrasonography is very important. As we were saying, the NICE guidelines actually do not recommend the ultrasonography if the UTI is not recurrent or is not atypical. So they would wait a second infection to have a ultrasonography, while I think, as Seda, that ultrasonography of the urinary tract is of the utmost importance, even at the first UTI, even if it's from E. coli and is not atypical. And it's important that urologist has the possibility to do the outpatient ultrasonography when he sees the first time the patient, without sending the child to the radiologist, because it's very, very important. So if a child we have to follow the guidelines. So if a child has recurrent UTI, if he has abnormal ultrasonography, either in terms of smaller kidney, dilatation of the upper urinary tract, dilatation of ureter, or mostly abnormal bladder, he should have a VCUG.
Thank you. Dr. Sardar, do you have different take on this? Because what I found with this bunch of various guidelines, the only thing which I could find, if the ultrasonography is normal, you can hold a VCUG. Because otherwise you see some people have taken a gender, some people have taken a time period, some people have taken a criteria of febrile UTI.
Yeah, I mean, I'm going to repeat myself. If the ultrasound is normal and the patient has undergone febrile urinary tract infection, the top-down approach can be an option to take. But again, like Walid is discussing, it's a matter of your social, economic, and healthcare system. I mean, all those issues are involved in decision-making. It's just one option to take to at least save a group of patients from VCUG. But it's not always the right decision, and it's the decision made on different circumstances. The problem with all those guidelines, I'm responsible of the reflux guidelines of the AU, ASPU. You cannot put every different factor into the guidelines. You just mentioned a couple of important points to make a decision. But it's not like a cookbook. You don't need to follow every aspect of it. You cannot. There may be some other different scenarios. And we try to deal with that by creating 9 different patient groups in our guidelines for the treatment part, not for the diagnostic part. And we've been criticized that this is not good guidelines. This is too complex. If you write simple guidelines, there are too many scenarios that you miss, and you cannot address every condition. But when you do try to address different conditions, then the guidelines becomes more complex. But that's the problem with the reflux. I mean, there are so many different factors involved, and there are also parental preferences, health issues, healthcare system issues, and many other things, medical legal issues. I mean, I know in states, if you don't do VCG after febrile urinary tract infection, and there's reflux and kidney damage, in the long run, you may even be sued for not doing the VCUG. So those are the things that you need to take into account when making decision or judging the guidelines. The guidelines are not cookbooks, really.
Yes, I agree with you. So just to summarize it, if we're having a scenario like this, what has to be done? And the 2 initial tests is the urine analysis followed by culture, depending on the findings, then renal bladder ultrasonography. Then you can choose whether you want for the top-down or top-up approach. So this is a semi-action statement, what has been raised by the point raised by Dr. Walid, whether you have to just inquire whether urine specimen was a clean catch, a clean cage or a catheterized sample. And, this is the colony count which has been suggested depending on the source of collection of the sample. And if there is a febrile UTI, the baby should undergo renal bladder ultrasonography, and VCUC should not be routinely performed. And that has to be ensured by taking a detailed history from the caregivers. So coming to this, Amir, can you recall the history? This child also had some bowel symptoms also. Do you remember?
Yes, sir. Yes, sir. Although the stool frequency was infrequent, but
Yes.
the Bristol, as per the parents, and the consistency of the stool was Bristol type 4.
So the question is, does bladder bowel dysfunction have an impact on VOR? I understand this just in a 18-month-old baby. Suppose he was a toilet parent. So tell us something about the correlation of bladder bowel dysfunction and vesicular reflux. Amir, are you there?
Yes, sir. Yes, sir. Yes, sir.
So tell us, yes,
Sir,
association,
sir,
yes.
yes, sir. I would like to quote two studies and trials. One is Swedish trial and reverse trial. In Swedish trial, it was discovered an individual with lower urinary tract dysfunction, they possess a high risk for experiencing recurrent UTI. And in the follow-up, they saw that 34% of the children with lower urinary tract dysfunction had recurrent febrile UTIs, compared to 20% of those with normal function. Although this difference was not statistically significant. And in reverse trial, the BPT was evident in 56% out of the 126 toilet-trained children, generally reflecting a mixture of both bladder and bowel symptoms.
So today we have ample literature that proves an association between reflux and bladder bowel dysfunction, a association between increased number of UTIs and bladder bowel dysfunction. So there is a connection on both. So you said that the authentic evidences have also come from a study from Swedish that reported 34%, and the most controlled trial on vesicular reflux intervention is 56%. So my question is to Dr. Walid. He has a lot of work on dysfunctional voiding. What are your thoughts? Because in India, the scenario is slightly different. And you had a lot of experience in sick kid.
Yeah, I might be a bit bold by saying I do believe reflux is most of the time secondary to something, whether it's secondary to a bladder dysfunction, whether it's secondary to posterior valve, or whether it's secondary to neurogenic bladder. And a long time ago, made me smile when Simona said when she was young, because we're all now have an experience in this field in terms of watching ourselves get older and getting to know our mistake of publishing things. I did publish a paper showing that the DVSS was a great indicator of reflux resolution, and that was in 2002 or 2003. In other words, I do believe that bladder bowel dysfunction has a huge impact on the reflux, and I think it may be a key factor in improving on reflux, or possibly even having a better success rate after surgery, albeit injection or open reimplantation or robotic even. So I think the concern I have is, as you said, Dr. Ansari, it's the difference in geographical definition of bladder bowel dysfunction. I mean, for us in the US, believe it or not, constipation and bladder bowel dysfunction is an epidemic. It's total epidemic. I don't see any patient who's not on some laxative. So for me, I cannot assume that BBD causes reflux, but I think what I can state now in 2023 is that BBD actually can make reflux worse. And that's why I think treating BBD could be an important factor in improving vesicular reflux, but not completely resolving it. And that's what I meant, that the evolution of reflux and how much we know about it does make a difference in how I see BBD now. I think it's an additional insulting factor for reflux, but it's not the only primary.
So before I go forward on in supporting literature, Dr. Simona, your experience on BBD and reflux?
I totally agree with Walid that in reflux we have to have a very functional mentality. I mean, we also always have to investigate what are the habits of the child, whether he drinks or not, whether he's obstipated, and how he avoids, especially soon after toilet training. And because in Europe as well in the US, I think that obstipation and very bad habits for drinking and eating are one of the main causes of UTI, whether or not there is a reflux. So if we don't treat the functional part of the bladder, and we will never get rid of the infection, and we will never get rid of the reflux. I think these three things are really so strictly linked together that it's very hard to know what is the first and what is the second. But it's they need to be treated all together. And if we treat just the reflux, we will never get rid of the infection anyway. So it's the functional evaluation of the child is really so important, and it takes longer to re-establish good habits, really long time.
Dr. Sardar, do you have a different thoughts on this? So before we get this notes from
yeah,
another
no, I'm sorry, boss.
Yes.
Yeah, I still don't. My concept still doesn't give me that. How do we actually define a bladder bowel dysfunction in a 1.5-year-old child? We probably may speak about constipation, but
yes.
If it is otherwise, I think on a regular basis on a toilet trained child, I think I have no other thing to add. But a non-toilet trained child who is not obstructed or there is no evidence of a valve, how do we actually define a bladder dysfunction? And how do we can only talk about constipation, but we cannot probably talk about bowel dysfunction too. Yes, Dr.
Yeah, we've been discussing this. I mean, we don't have any criteria to define bowel bladder dysfunction in a non-toilet trained children. So they are through the transition of being toilet trained, and they most probably have some sort of a bladder dysfunction, either frequent voiding or some uninhibited contractions and high pressure voiding, some form of dyssynergia. So most probably this child has some sort of a bowel bladder dysfunction, and considering the presence of constipation, that increases our suspicion that the child, sorry, the child is not doing well in that sense. But we're not able to define bowel bladder dysfunction for this age group if they're not toilet trained, because all the criteria we'd be looking at would be in a child with toilet training. I do agree that bowel bladder dysfunction has a huge impact on the occurrence of reflux. And the good thing with bowel bladder dysfunction, it gets better in time, it improves, and it goes normal as the child is growing older. This is the whole rationale of actually the conservative management of reflux. Because the bowel bladder dysfunction is getting better or improving, we see the resolution of reflux. It's not the resolution of the anatomy there. It's mainly the resolution of the bowel bladder dysfunction that helps the resolution of reflux. But it's not a sole factor. It is a contributing factor. But most often there is a deficiency, anatomic deficiency, that causes reflux. Depending on the severity of the anatomic deficiency and the bowel bladder dysfunction, either you have high-grade reflux or more clinically important reflux or low grade of reflux. If there is no resolution after bowel bladder dysfunction treatment, or as the child has grown old, still you have reflux, then it's just only anatomic deficiency that you need to correct surgically. Other than that, what we're doing before the surgery, conservative management, double time voiding, urotherapy, frequent voiding, etc. The whole urotherapy concept is just helping the improvement of bowel bladder dysfunction so that the reflux will either go away or become better or less clinically important in time.
Thank you. So just to further aid it, these are some of the inferences from the post-hoc analysis of RIVER trial, the QT studies exclusively done in toilet-trained, and it also proved that the children who are having both VUR, they have a high risk of developing recurrent UTI and receive the great, and these are the kids who basically benefit more from the antibiotic prophylaxis. And the basic idea is screening and the treatment of BBD may reduce the recurrent UTI. And subsequently, and this also has an impact on the resolution of the VUR. And this is the group where it has been studied that those who have been given antibiotic prophylaxis, children receiving antibiotic prophylaxis, the resolution rate was better, those who did not have BBD. And on the left side, the resolution rate was 31%, because these are the kids who had BBD, and while on the right side, this HABD on the right side who did not have BBD, and the resolution rate was 61%. And further, and this is the group which has been analyzed in terms of open surgery, endoscopic. While in surgical group, there was no impact on the bladder bowel dysfunction, only the impact was studied in the endoscopic group. In those kids who had BBD associated, this resolution after endoscopic intervention was poor, and those who did not have, they had a better effect of endoscopic treatment. Yes. Sardar, will you write to comment on this? A lot of experience in endoscopic management.
Me? Yeah, I think that's a good candidate for endoscopic management. We have to stop reflux for this patient because of recurrent urinary tract infections. But I understand that he was not put on prophylactic antibiotic therapy. Was he or not?
No.
Not
Just
yet.
in the discussion, it will come.
One option then would be to circumcise and put on antibiotic prophylaxis. This is one option. And there is a high chance that we are going to be able to control the infections and allow the reflux show spontaneous resolution. Or another option, and also work on the obstipation. Yes, Malik is reminding me. So the best option, but this is something to discuss with the parents. Put antibiotic prophylaxis, do circumcision if they're happy with that, and do work on the constipation. And there is a high chance that the patient will not have urinary tract infections. And after toilet training, he may even be getting better in terms of reflux resolution. Another option to take would be easy, minimal invasive surgery, doing injection. That's an acceptable option for this case. But again, even after the injection, you need to keep the antibiotic prophylaxis for some time, and you still need to work on the constipation.
Right. So, Dr. Ashish, can you take the hot seat now?
Sir, Doctor, the host, can they unmute Dr. Ashish? They can allow. Okay, sir. Allowed.
Please, yes, please allow Dr. Ashish. So, Dr. Sardar has given you a clue. How do you want to treat this child? Ashish, are you there? Yes. Yes, you are the consultant now. You tell us what advice you want to give to the family. You have to improve your audio.
Everything. Conservative, reflux, minimal invasive implant, and an open drain.
Well, I would not do open.
तेरी आवाज नहीं आ रही वाले से ऑडियो से कर ले
Audio. Improve your audio, Ashish.
Dr. Ashish would like to take my Zoom. Ashish?
Okay, yes, you share with him. Yes.
Yes.
Sir, am I audible now, sir?
Yes, but you are having two systems on. Hannah, put one of the system off. Okay. So now the baby is with you. The family
Yes, sir.
wants. Yes.
So we have 1.5-year-old male child who is having a recurrent episode of febrile urinary tract infection with a background of constipation, sir. So first, as we discussed earlier, we will be managing the constipation part aggressively. And second, we will be starting this baby on a continuous antibiotic prophylaxis.
So you want to take antibiotic prophylaxis. This is what Dr. Sardar has given you a clue.
Yes,
Is
sir.
there? Or is there a rationale for this?
No, there is a rationale for it, sir. Because when we
What
will
is
starting the
rationale of antibiotic? What is the rationale of antibiotic prophylaxis in vesicular reflux?
So there are three rationales, sir. First, when we were using antibiotic, the urine will get sterile, and once the urine gets sterile, then the chance of having a pyelonephritis will decrease, and it will also help in achieving a faster spontaneous resolution rate, and the chances of febrile UTI incidents will also decrease, sir. So, which is being supported by various studies also, sir, which has been published.
Antibiotic prophylaxis does not have any role in spontaneous resolution. Yes, this can keep the urine sterile, and there is a possibility this will prevent the breakthrough UTI. This may also not prevent the scar also. Okay. So can you mention some of the studies which support your statement that antibiotic prophylaxis really help in vesicular reflux?
Sir, we have this Swedish trial, sir, in which the Swedish trial and river trial which has been conducted, sir, according to which tell us that the antibiotic prophylaxis do have a role in decreasing the episode of febrile UTI, sir. So a Swedish trial was a multicentric randomized trial, sir, which has been conducted in Sweden, where dilating reflux of grade 3 and grade 4 were taken into consideration, and two arms were made. In the intervention arm, prophylactic antibiotics was given, and in the control arm, placebo was there. So the arm in which the intervention was done, the chance of breakthrough febrile UTI was 19%, whereas in the arm control arm where antibiotics were not given, in them the chance of breakthrough urinary tract infection was around 60%. So the difference of antibiotic prophylaxis was around 35%, sir.
Okay. So you mentioned the Swedish trial.
Yes, sir.
Any other study?
Yes, sir. There is one Australian study known as PREVENT trial, sir. It was also a randomized trial, sir, where 56 children less than 18 years of age having reflux were included. There also we have two arms. One was the intervention arm where the antibiotics was given, and one was the control arm where nothing was given, sir. So the arm where placebo was given. So in the arm where the antibiotics trimethoprim sulfamethoxazole was given, when it was compared to the control arm, then the intervention arm was had 6% less incident of breakthrough urinary tract infection.
Okay, so you mentioned the Swedish trial, just to revise it for the sake of PGs. And another, there was the benefit was to the tune of 35% that in the antibiotic group. And another study you mentioned is the Australian this study, although the number of the children was small, but all these studies have been criticized because of their study design. Yes.
Sorry, sir. Sir, can you please repeat the question once, sir?
All these studies have been criticized because of their study designs.
Yes, sir.
So how could you improve all these flaws of these studies? These studies showed a benefit, but after this, there have been many non-randomized studies also which said that antibiotic prophylaxis is not at all effective.
Sir, the largest Yes, sir. The largest study which was conducted was the River trial, sir, which was done in USA, sir. It was a randomized, double-blinded, multicentric study, sir, where more than 600 patients were included, sir. In them, all the patients who were having either a first or second episode of febrile UTI with vesicoureteric reflux were studied. Here also we have two arms, sir. One was the intervention arm and another was the placebo arm. So in the intervention arm, trimethoprim sulfamethoxazole was given, and the primary outcome of the study, which was studied, was whether this prophylactic antibiotics prevented the episode of this recurrent febrile urinary tract infection, and the secondary objective was how was its effect on renal scarring and what was their antimicrobial resistance in those cases, sir. So it was seen that in the control arm where the trimethoprim sulfamethoxazole was given, there was 50% decrease in the prevention in the episode of febrile UTI, sir, in the intervention arm, sir. But what was the negative part of it was that the chance of renal scarring was doesn't increase, doesn't depended on this intervention. And second, there was a higher chance of this resistance towards trimethoprim sulfamethoxazole, sir.
Okay. So you told that even if there was some flaws in these studies, but the most authentic trial so far in relation to antibiotic prophylaxis we have is this River trial, and this was a randomized control trial with placebo and intervention arm, and this recurrent UTI could be reduced by a percentage of 50%, and this was particularly effective when the baby basically presented with febrile UTI, and those children who had a BBD, it was more effective as compared to the non-BBD group. So based on this, and there are many other recommendations from this AU also. Now, I would like to have opinion from this faculty. Dr. Simona, what is your policy of giving antibiotic prophylaxis?
Okay, now I want to go back to this case first, and so this is a male child of 1.5 years, which has a normal looking bladder because the bladder is roundish and smooth. It has a normal urethra. It has a low medium grade reflux on a single side with a focal scar, which we don't know could be just temporary. I mean, it has still chances to recover. And he has, apart from being obstipated, it seems that he has no major bladder dysfunction. So in this case, and he had, let's say, 4 previous febrile UTI. So in this case, we can, as Seda said, we can offer the parents 2 options. One is to have long-term prophylaxis till the child is out of nappy, which will probably occur in about a year time because he was already 1.5 years. Or we could offer him to go to endoscopic treatment of reflux, and we should consider endoscopic treatment of reflux if he has breadth and circumcision, if he has breakthrough urinary tract infection, febrile UTI, while he's on prophylaxis. This is what I would try to summarize. It's very important, I think, in the evaluation to see how the bladder is, what is the configuration of the bladder, how is the urethra, as I said, because I would challenge one phrase that was on the previous slides, which was that sterile reflux is not harmful. So sterile reflux is not harmful, provide that the bladder is normally is functioning normal. Because if you have a severely dysfunctional bladder, either such as in a valve or in a neurogenic bladder, you can have severe scars in the kidney, even though you didn't have pyelonephritis. So that phrase should be completed, said, provided that there is no major dysfunction, sterile reflux should not be has to be considered not harmful. Do you agree on that?
Correct, absolutely correct. That should be that was a half written. And most of the time it is repeated in the textbook also, but it should be in the absence of any bladder dysfunction.
Yeah. So, and I would add one thing. There is a very recent study, multi-center study from Milan, which is the Predict trial from Giovanni Montini. Is a which was recently published on the New England Journal of Medicine. Montini is a nephrologist. He's one of the best nephrologists in Italy, and he has long been pushing the idea that reflux, especially reflux which is detected because not after UTI, but because of prenatal diagnosis of urinary tract dilatation, is not harmful. So he pushed forward a prospective trial with infants and children up to 3 years. They were 75% males with high-grade reflux, 3, 4, and 5th grade, and they were randomized to have either prophylaxis or nothing, just observation, because he was the idea that it was safe to have no prophylaxis even for high-grade reflux and even for males in infancy. And the end of the trial was that in this group of patients, actually, prophylaxis gives a mild reduction of febrile UTI, but it has no effect on the appearance of new scarring. So in males, infant males with a high-grade reflux, let's say from the dilating reflux, still prophylaxis is advised, is recommended, and it should be either, offered up to the time of being out of nappy, or probably 1 year without infection. This is another new recent concept.
Okay, thank you. Dr. Walid, what is your policy? Because sometimes in India, people use antibiotic prophylaxis. Some give double therapy and triple therapy. What they give for 6 months, one antibiotic. For the next 6 months, they change another oral antibiotic. And the third time, they give a third oral antibiotic to avoid resistance. Or you give a single antibiotic for longer period.
Yeah, for young patients who are not vocal, who I worry that they may have infections and be late to present for treatment, I do give antibiotics. Obviously, I don't tend to alternate different types of antibiotics, except if the patient is having recurrence, positive cultures, but not for sure suggestive of pyelonephritis. And this is why I also worry about the urine analysis and urine culture being done frequently, because unfortunately, we are still relying on a urine analysis definition since the 1950 on what is a positive culture, which is not really an accurate way of doing it. So we're trying to really look at different variables in terms of whether there is an infection or not. So to answer your question, doctor, I'm sorry, I would keep the baby on antibiotics, single or type of antibiotics. It's TMP or Bactrim or Septra. And I will follow them up till they are toilet trained, because I know that somebody was asking how long do we keep those patients on antibiotics. If the patient is doing well on antibiotics, I will actually keep them till they adopt what I call natural habits to avoid infections, such as drinking a lot of fluids, voiding frequently, avoiding constipation. I tend to have a very low threshold for this particular patient that you presented, because there is a pyelonephritic change. And if there is any one time a breakthrough infection, I would consider doing a surgical intervention, be it an injection. And I just want to follow up on Simona's point, by the way. I completely agree that infants who are born with prenatal history of hydronephrosis and found to be refluxing, I actually call them the 4 Bs. They are usually boys, they have bad kidneys, they have bilateral reflux, and they have bad reflux too. And those patients have a reason for their hypoplastic kidneys. It's because of the embryology of the urethral bud. It has nothing to do with reflux per se. And that's why I completely agree with her point that those patients don't have possibly a high risk of scarring. It's just they are born with a very low kidney function. But I answered the question about antibiotics. We tend not to, Dr. Sardar talked about the medical legal issues here in the US. There's another thing that we worry a lot here in the US on is whether the insurance will approve the antibiotics we want to give the patient or not. Sometimes they may actually not approve certain medications, and the amount of money we pay or the family pay for a medication can be so astronomical that we have to really alter the medication that's cheaper for them. And this is why it's a call for another meeting, maybe to talk about how population-based data can have a huge impact on guidelines formation or development. But that's the long answer to your question. So apologies for keeping it long.
Yes. So this is what the topic which Dr. Walid has also, this is also a very controversial and debatable topic. How once the antibiotic prophylaxis has been started, how long to continue this antibiotic? Will Dr. Sadar, will you comment on this?
He is coming.
You first by this time.
Okay, no, okay. He is here.
Yeah, okay.
In the
meantime, Ashish, you can comment. How the baby has been given antibiotic prophylaxis. How long we will?
How long you will continue antibiotic?
Okay.
Yes,
Before I comment on this, I'd like to comment on this Montini paper. This paper looks at patients who had not had any previous urinary tract infection.
Yeah, I say that.
I think that makes a big difference. Yeah, but it's a very benign population again. This is a typical pediatric paper looking at always benign group of patients. Our patient group, like the patient that we're discussing now, most of them will have several urinary tract infections. Then you make a judgment on what to do. And this antibiotic prophylaxis protocol for the paper in Montini that Montini wrote would not match to this patient that we're discussing now.
You're right.
I think I need to clarify that because it's a more benign without any symptoms of urinary tract infection in the past. And even in that group, antibiotic prophylaxis stopped the occurrence of the first UTI. So I just want to clarify. How long does it go? I don't know. Nobody knows. And I personally, I like to do it till after toilet training is complete. I'm sure there is no bowel bladder dysfunction. The toilet training is complete. The patient is doing well. The constipation is gone and everything, which is around the age of 4 to 5. I will stop antibiotic prophylaxis and we'll see what's happening.
So let us have, because what is the general findings in the literature? When everything is going as per the expectation, antibiotic prophylaxis has been started. There is no breakthrough infections. And if you see, the AUA suggests that the normal resolution rate, regardless of the age, is nearly 20%. So if you multiply it by 5, so in the next 4 to 5 years, when everything is going normal as per the schedule, then in next 5 years, that is reflux should resolve. And subsequently, and this is another study which shows that most of the scars which have been reported are within the period of 5 years, and many are under 4 years, except one study by Dr. Shimada, in which they reported scars even at the age of 8 years also. So most of the time, if you apply the logistics as per the AU guidelines, resolution as well as the occurrence of the scar, that usually happens within a period of 4 to 5 years. So those kids who are doing normal, and you can stop antibiotic prophylaxis over a period of 4 to 5 years when everything is going as per the normal expectations. And further, in the next slide also, and this is the IRS study of the 10 years, and they also reported and that this 10 years data, they did not report any new scar after 4.5 years. So beyond 4 or 5 years, there is hardly any rationale of continuing antibiotic prophylaxis in those children who have been stable for long. Dr. Walid, your thoughts?
The question is duration of antibiotics.
Yes, yes.
As I said before, I usually keep them on antibiotics till they acquire the natural habits to avoid infections. And those natural habits, as Dr. Sardar said, the toilet training, making sure that they are basically drinking, having no bladder bowel issues. And I'm very strict on this by making sure that the family will document that through a voiding diary for at least few weeks, once every weekend, and make sure that they do actually report the Bristol score for their kids' bowel movement. And I tend to do this not because I want to only confirm that the patient is adopting the natural habits. My biggest concern is that the family may actually dismiss supervising their kids' bladder and bowel function. And then any single infection that can happen in this family dynamics will push me to operate when it's not really indicated to operate on them. Because I don't even do a repeat VCUG on patients with VUR, by the way. I just do it once and follow them based on medical or clinical history. So I usually keep them till toilet training and till confirming that they are not having bowel bladder function.
Correct. So Dr. Ashish, this was highlighted earlier also. Will you advise circumcision along with the antibiotic prophylaxis?
Actually, circumcision do reduce the chance of recurrent UTI, and in this case, I would advise circumcision to the child, sir. But the point which has to be kept in mind is that it comes at a cost, because studies have shown that in a normal patient, in order to prevent one episode of febrile UTI, we need to do more than 100 circumcision. But in a child who is having a high grade vesicoureteric reflux like type 3, type 4, in them, to prevent one episode of febrile UTI, we need to do 4 circumcision. So in this particular case, since the kid is having recurrent UTI, I will advise.
Dr. Simona, what is this practice in Europe?
Sorry, I think it depends on the countries. Because let's say in UK they are more, or in France they are more for circumcision. Italy is less prone to circumcision, but in my center, if I have a higher reflux patient, which UTI or a bowel patient, I think that circumcision is recommended.
Okay.
It's highly recommended. Not for prevention, but in infected patients, patient that had at least UTI.
Okay, Dr. Sardar.
You would not be surprised if I say that we do circumcision and all. Well, but there's enough data there's a Cochrane analysis, you know that. Yeah. If you do one circumcision, if you do 9 circumcisions in normal children, you stop 1 acute pyelonephritis. No, I'm sorry. If you need to do 120 circumcisions to stop acute pyelonephritis in normal children. For reflux in children, you need to do 9 circumcisions. So there is a clear advantage of circumcision preventing. It's as good as almost antibiotic prophylaxis. But at the end of the day, it's a matter that to be discussed with the parents. We don't even discuss this with the parents. We just go ahead and do the circumcision.
So I don't entirely.
May I add one other thing, please? We also have a lot of circumcisions in the US. The only one thing that I would just add to Dr. Ashish's comment, the circumcision and UTI is only protective in the first year of life. And this data had been quite proven in the literature. After 1 year of life, circumcision does not really decrease the risk of UTI. So if a patient is coming beyond the age of 1 year, I would possibly be hesitant to let the family think or believe that there is a need for that. The second thing that you might be and I'm quite sure that you're aware of, is that even, and this data have come recently, that if you have a severely phimotic patient who is uncircumcised, you can possibly start them on betamethasone cream or steroid cream, and that can also decrease the risk of infection in those patients if the family is not willing to have a circumcision.
So,
May
I have a comment? Yeah. Dr. Ansari.
May I add that betamethasone treatment for phimosis in children is very common in Italy, but generally when I go for a endoscopic treatment of reflux because of recurrent UTI, since the patient is under anesthesia, then I will go for a circumcision without any increased cost or any increased anesthesia. I think it's fair. It's hard to define then if the improvement is due to the endoscopic treatment or the circumcision. So it's less scientific. It's hard to get scientific data from that. But I think from a clinical point of view, it's worthwhile.
So Ashish, will you advise screening culture? This is a common practice in India. While the antibiotic prophylaxis, child is stable, no infection, no lower intestinal symptoms. But even then, cultures are done, urine analysis is done. Will you advise?
So on the basis of literature, it should not be advised, sir. Only the advisable thing is to get a urine analysis done and do a routine urine routine microscopy. In that routine microscopy, if we are getting evidence of bacteria, then only we should proceed towards urine culture and sensitivity.
Dr. Sardar, what is your practice while starting antibiotic prophylaxis? How do you follow this? Like with the urine analysis, or do you advise in between the cultures?
Dipstick. Yeah. Well, we would do just dipstick screening for like occasional, like we suggest every month or so. It's not a very rational approach because there are times that you may be missing the urinary tract infection. Most important are the symptoms. We explain to the parents the symptoms very clearly. If there are any symptoms, they would go ahead and do urine analysis. If not, they can do occasional dipstick screening of the urine. That's it. And how occasional, depending on the availability of the healthcare, the system, and everything. It's a matter of to discuss with the parents. Some people are very obsessive about it. They do it every week. But they need to understand that there is a risk of urinary tract infection, which can be missed. So they need to do some simple urine tests with dipstick.
So one comment, quick comment, Ansari. Yeah, with your permission, regarding these.
Please go ahead, please.
Yeah, so regarding the circumcision, I do practice. Specifically, see what important is that the retractability of the prepusal skin. So if it is, if you are able to retract, mother is able to retract and clean the prepusal area properly, that is what it requires. So any case where that is not possible, right, we can use a steroid cream for a couple of days. If it is not working, then this cleaning is mandatory. And in that case, we have to go ahead with the circumcision. That is what even one of the segment of face-to-face with Anthony Curry, we discussed this. And this we see even in our practice, 2 years, 2.5 years, 3 years, if the child's skin is not retractile, or it cannot, mother is not able to easily retract and clean, then we have to go ahead with the circumcision. Before that, we can have a definitely trial with the steroid application. If with that we can retract the skin gradually, then it's perfectly fine. But it's a important thing is that cleaning that prepusal area and glands.
Right. So do we have, Dr. Chandra, do you have any thought on screening cultures? Because it's very common in various parts of the India. Dr. Chandra?
Dr. Ansari, probably Chandra has left because of some Christmas related function.
Oh yes, he informed.
That's what he has messaged me. Yeah.
This is what I said, that we have to be part of the Christmas celebration. But
so
he has gone.
What I suggest my parents, that these are the symptoms. If you need to go for any of these symptoms or for any reason hospital or no need, then at least collect the urine in a sterile bottle and get it checked with these because I agree with the dipstick test. Generally, we do that also, but even microscopic examination and no symptoms, both together satisfied during the antibiotic prophylaxis, I think.
Okay, right.
May I
please
add? Yes, our patients are instructed to do dipstick only if the children are symptomatic. If they are noisy, if they vomit, or if they are, different from usual, or if they have febrile. So they do dipstick at home in very quick manner, and if the dipstick is positive, either if the child is very low symptoms, then they will go for a urine collection and urine culture the day after, or if the child is clearly sick, they will go to the emergency with their positive dipstick. But we do not advise routine cultures or routine dipstick for asymptomatic children on prophylaxis. Because then if you treat them and they are asymptomatic, you just get more resistance.
So that point is well taken. If the urine analysis dipstick is showing abnormality, then go to the culture. Yes. So these are some theoretical part, spontaneous resolution. What are the various risk factors? The PG students can get it from the literature also, just to share with them. And these are some of the new things. Though it has not been standardized, there are the other scores besides the conventional features which has been described in the previous publications. And another is the vesicular reflux index, and this is a 6-point score depending on the 4 factors. And they have basically this if it is less than 2 and 3, the resolution rate is this VOR score is higher, while if it is 4 and 5, the resolution rate is poor. And similarly, another study which has been done is the spontaneous vesicular reflux resolution based on the ureteral diameter, where they have taken the ratio of this L2 vertebra and the retrovesical ureteric diameter, and they have inferred that those who are having this ratio less than 0.3, the resolution rate is better, while those who are having greater than 0.3, then there are high chances that reflux may persist. So Ashish, the next question to you is. Yes.
करेंगे तो कल सुबह तक भी चलेगा. No, I'm saying that if we continue, we'll go on till tomorrow morning too. I think we should go.
So, what is the association of renal scarring with reflux?
Sir, if a urinary tract infection is being associated with vesicoureteric reflux, then there is a chance of getting a higher renal scarring. More the number of urinary tract infection, more will be the renal scarring in those particular cases.
So these are the general findings. The UTI and the VOR causes more scarring than UTI alone. Greater number of the UTI is associated with more scarring, and the abnormal bladder dysfunction, as previously been discussed, is more associated with the scarring as well as less resolution. And this is also true that antibiotic prophylaxis may not be protective in all cases. And this has been shown that the UTI and VOR, when they are coexisting, they causes more UTI, more scarring as compared to the UTI alone. And it is seen that the comparison, the incidence of this renal scarring when both are present is 2.8 times for patients as well as 3.7 times for renal units. And this has also been shown that the greater number of UTI, more the chances of renal scarring. Now coming to the practical questions, what are the indications for intervention, Ashish?
So the clear cut or the absolute indication for intervention will be a treatment failure where a child is on a continuous antibiotic prophylaxis and he is having a symptomatic breakthrough urinary tract infection. There are other relative indications like if the family is non-compliant and is at risk, if there is a parental preference for it. There is a failure of spontaneous resolution after wakeful watching, or there is a progressive renal scarring on follow-up scans.
So these are some of the indications for interventions. And for theoretical purpose, it has been broken in two parts, absolute and the relative indications. That all depends on individual practice. And if the child is on antibiotic prophylaxis, then how do you define the treatment failure? And from where this has come?
So the definition of treatment failure was given by River trial, which has defined as if the child is on continuous antibiotic prophylaxis and still he is having a 2 febrile recurrences or 1 febrile recurrences with 3 symptomatic recurrences or 4 symptomatic recurrences over the period of study period that was 2 years, or he is having any new or previously worsening scar on a follow-up scan at 1 year. So these are defined as a treatment failure, sir, according to River trial.
So most of the studies, they have taken a very ad hoc definition of the treatment failure, but I think I could find one of the most authentic definition has been given in River trial. And so how do you counsel these families? Suppose that antibiotic prophylaxis has failed, and how do you counsel these parents for open or endoscopic treatment?
Actually, in the management of vesicouretic reflux intervention, counseling with caregiver and care provider, there is a very crucial role of the both. It has been seen that there are various approaches like open surgical approaches, minimal invasive approach like laparoscopy and robotic, and endoscopic approaches. We have to counsel them regarding the success and resolution rate. So it has been seen that the resolution rate of open surgeries are better than that of an endoscopic surgery, with resolution rate of open surgery, the success rate nearing around somewhere 97-98%, and that in an endoscopic surgery around 80 to 85% after single injection.
So, Dr. Simona, how do you counsel your patient for a particular approach?
I must say that now I reduced the indication to open surgery to very complex reflux, which means very high grade with dilating and convoluted ureters, in which I think if I go for an endoscopic, I will have very bad contraction of the ureter and I will have obstruction, or duplex system with ureter seal, or but I mean complex situation. The indication for open are very, very little. Most of my patients are treated by endoscopic injection.
Okay. Dr. Wali, do you have some other approach?
Nothing to add beyond that. I have the family make a decision with me. I do practice shared decision making with the family. And sometimes for low grade, if they are really not open for an injection, I actually may go for an open surgery. But we don't do reflux surgery as much as we used to do. But nothing to add. Thank you.
Okay. So just pass some of the slides quickly. The type of reimplantation, suppose that the family has opted, because in India many of the surgeons, whether pediatric or the pediatric urologists, they are going for the open surgery. And incidentally, this deflux is not licensed in India these days. We are having a Turkey product Dexel right now. So most of us are using that. But as such, the two common techniques, polytunnel, Leadbetter or Cohen, that all depends on the surgeon's choice. And the complications are more or less comparable without any statistical difference. Slightly more complication in cases of Cohen, but not a very substantial difference between the two.
May I
Yes,
Sorry,
please.
may I add one thing?
Yes, sir.
I think that we should remember, or we should keep in mind, that our children will be adults. And in adult urology, now most of the procedure are done endoscopically. So I think that if we go for a reimplantation, we should try to have the ureteric orifice in a position that can allow an endoscopy of the upper urinary tract. So, which is not the case in the real Cohen transtrigonal procedure. Because this patient will one day have a stone, they could have a tumor of the upper urinary tract, they could have any doubt about it. So they need to be endoscopicable assessed. So the Cohen procedure will make it very, very difficult for the adult urologists, which are our colleagues.
Dr. Walid, your thoughts?
Actually, I'm a big fan of extravesical reimplantation, except if the patient does have an element of bladder bowel dysfunction and they do have bilateral reflux.
Right.
For bilateral reflux and an element of bladder bowel dysfunction, I do Cohen. For any other patient with unilateral reflux, if I want to do reimplantation, I like the extravesical reimplant.
So, Dr. Sardar, yes.
Sardar is not in here at this point.
May I say that I, since 20 years now, I do a modified Cohen, which means I do it transvesically, but then transvesically I move up the muscular orifice, and then I do a kind of J tunnel so that the ureteric orifice is quite on a trigon and can be easily cannulated endoscopically. So it's not really a true polytunnel bladder, which should be done extravesically, but it's not transtrigonal as it should be a Cohen, because in such way you may allow any further endoscopic approach to the upper urinary tract.
So it is just like a cranial location of the new.
Yes.
Yes. Okay. So
I think it has been described somehow, but I don't know.
Yeah. And suppose, Ashish, this was the MCU to begin with.
Yes, sir. Sir, if this was a MCU, then with ureteric reimplantation, we would have considered for ureteral tapering also, sir. So as to achieve a proper length to diameter ratio, which will help a better coaptation and better peristalsis.
Okay, because we are going little just to quick pass through this. And this also, I would just like to have an opinion on regarding the kinking. Dr. Walid, because lot of kinks are seen on many VCUG. So how far one should go for tapering or this plication or this folding?
So, I mean, if I do have a kinking in a ureter, if I'm doing a reimplantation, as I said, I like to do a extravesical on for unilateral. For this particular VCUG you just showed, Dr. Ansari, I would go approach it extravesically. I will straighten the ureter, and I always have I tell people that the kinking is important in a way that you want to be strengthening, lengthening the ureter so you can avoid those kinks. And the way I can tell if it's straightened or not is I pass in a double J or I pass in a catheter. And if there is a long ureter, which I have seen, and most of us have seen, that the ureter will reach the mid-thigh of the patient when you dismember it, then I usually take the length of the ureter to the pubic bone, and then I taper from there up to the iliac crest, to the pelvic brim. So I do taper if I know that there are kinks and the ureter is more than 1.5 centimeter.
Okay. So just to quickly pass, these are the various non-excisional tearing, stricture, and the calcium skin, and which can be taken. But there is another one, classical, is the handle. And when the ureter is too bulky, then this excisional method can also be done. And now coming to the most popular method, endoscopic management. Ashish, tell us about the sting and the hit.
The sting and hit, these are the minimal invasive methods which are usually preferred for a lower grade reflux like type 1, type 2, and type 3 refluxes. Depending on where we are injecting the bulking agent, there has been two techniques has been defined. One is a sting technique where we go submucosally just below the ureteric orifice and we inject the Teflon, and another is a hit technique. In hit technique, we go intraureterally and there we give the bulking agent like deflux. Hit can again be of two types, sir, single hit and double hit. If we go and do it in more proximally, a single shot, then it is a single hit. If we are giving it both in a proximal as well as distal segment, then it is called double hit, which is the most preferred technique which is being used nowadays, sir.
Okay, so do we have Dr. Sardar, Dr. Malik? Do we have Dr. Sardar back? Because he has been doing lot of stings. Dr. Anil? So anyway, Dr. Simona.
Yes.
So what are you practicing, sting or hit?
It depends actually on how wide is the ureteric orifice, which means if it's the old classification was like a stadium or a golf hole. If it's not too wide, then I would do a sting. If it's very wide, I would do a hit. So I would go just at the entrance of the ureteric orifice and then lift it. So it's very important to have a rigid needle and then try smoothly to retract it, and so that you have a nice volcano orifice. With some materials, I would advise against a double hit, because then you can increase the risk of obstruction. So I think that the technique actually depends on the morphology of the ureteric orifice. It's not a question of I can do always a subureteric or injection or always a hit technique. It depends on how wide is the ureteric orifice.
Correct. So Dr. Walid, what is your preference most of the time?
I do the hit technique. I do the hydrodistension, and I actually inject in the ureter itself. But I have to say, I am very weak at giving a good an indication that my surgical approach is good, because I don't do VCUGs post-operatively. I actually do the hit, keep the patient on antibiotics for a while, and then stop the antibiotics and see how they do, and rarely repeat the VCUG if they have another infection. And I work them up again as a new patients if they come back with another infection. So for that reason, I think I'm completely inaccurate if I say that my technique is as good as the open approach.
Correct. Do we have Dr. Prasanna? What is your choice? Yes, Dr. Simona, you wanted to add something.
Yeah, I mean, the patient that I treat endoscopically are highly selected patients which have UTI despite prophylaxis. I mean, febrile UTI despite prophylaxis. So, and as Walid, I'm not doing VCUG post-op any longer, but as long as the patients are asymptomatic. So I must just suppose that that reflux is not there any longer, or it has been downgraded so that the patient has no longer UTI. Obviously, VCUG is repeated if the patient becomes symptomatic again, and at that point, the choice is between repeating the injection or going to reimplantation, independent of the technique.
What is your policy? Do you recommend routine VCUG after this endoscopic management, or just follow the child?
I don't do VCUG any longer, but I think I come from experience where for 20 years we were treating something like 350 patients per year endoscopically. And so we after a couple 10 years, we stopped doing VCUG and limiting it just to symptomatic patients.
So these are the results of endoscopic management. Obviously, this is given a good success rate in low and intermediate, while slightly inferior in cases of grade 4 and 5. And while counseling the families, we have to tell the parents that there is a 20% failure over a period of 2 to 3 years, because the long failures after endoscopic management have also been reported. Displacement of the implant, or there may be some dysfunctional voiding with vent undiagnosed. Dr. Bhatt? Yes, please.
Sorry, no, I just wanted to add that ultrasonographic follow-up is of the utmost importance in this patient that have been treated endoscopically, because I have recently seen obstructed patient with huge dilatation, and the longest one was 6 years after the endoscopic treatment. So I have to warn against discharging this patient from any further follow-up after endoscopic treatment.
Thank you. So Ashish, what is the sequelae of untreated vesico-ureteric reflux?
So the sequelae of untreated vesico-ureteric reflux will be a reflex nephropathy, sir, where we will be seeing a progressive focal interstitial fibrosis, which will ultimately lead to focal segmental glomerulosclerosis, hypertension, hypertension, CKD, and ESRD. Sir.
So this is another important question. How will you follow up a child with vesico-ureteric reflux? Suppose this baby, as you said, was put on antibiotic prophylaxis.
So what we will be doing is that all the kids need to be a follow-up. So what we will be doing is annually we will be taking the general assessment in terms of height, weight, and blood pressure of the child. And this we have to do annually till the child achieves adolescence. And second one is we have to advise urine analysis annually. And if that urine analysis shows any feature of bacteria, then we have to go for urine culture. Then we have to do a annual ultrasonography to look for the renal growth and any scarring which is being occurring or not. VCUG for this particular child we can avoid. It can be an optional thing since he is only having a grade 2 reflux. But if a child is having a higher grade of reflux, then we need to do VCUG annually, sir. Annually or at a span of 1 to 2 years. Sir. And DMSAs can only if we are getting any abnormality on ultrasound, or we are having a suspicion of high grade reflux like grade 3 to grade 5, or there is an increasing trend of serum creatinine.
So there are various recommendations by different guidelines. There is so much similarity, but little differences also. So I asked Dr. Walid, how do you follow your patients with the antibiotic prophylaxis?
Just follow them up based on the clinical findings. So I tend not to do a repeat VCUG. I think there's a lot of morbidity with repeat VCUGs as children gets older. I do give a list of recommendation to the family to seek medical help. I always tell them that there is an interesting study that showed foul-smelling urine plus fever and irritability can be suggestive of possible urinary tract infection. So I usually tell them foul-smelling urine alone does not mean too much. And I tend to see them frequently. If I have a boy with reflux, I may have a higher threshold to do too much studies. But just females, I am tending now to be very specific and indicate in my medical record that as they get older, they need 4 tests that I always would suggest that the primary care physician or family physician would do. Serum creatinine at one point, urine for protein, creatinine, and blood pressure measurement. And those are 4 variables that I believe would be very much worthy of following up in the patients, especially females, because of their high risk of being infected as they get through sexually activity as well as pregnancy. But I don't do VCUGs, and I really insist on making sure that I only do VCUG if I'm going to be operating on the patient.
Right. Dr. Simona, do you have some different practice?
No, I do the same. I just ask voiding charts in females when they get to school age, like 6 or 7, because I want to be sure that they have been acquiring proper habits regarding drinking habits, toilet training, and stools. Sometimes they are perfectly normal, but they have retentive habits, and they need, and parents do not follow them any longer. So unless you specifically ask for a voiding chart, they would not refer that.
Okay. So we are left with 5 slides. If you do you want to continue, both of you? I'm asking. This is because already it is more than 2 hours. We are having 5 or 6 slides left.
I was late, so I should stay. I'm happy to stay.
Thank you so much. So,
Yeah.
so Ashish, do genetic factors play any role in vesiculated reflux?
Kindly allow Amir.
Sir, can you allow Amir sir?
Oh, Bilkul, sure, he can come. Anybody can take this question.
Yes, they do.
Mhm.
Sir, he need to be unmuted from your side, sir.
Navneet ji, kindly unmute.
Audio. Hello? Okay.
Yes.
Yes.
Hello, am I audible?
Yes, please go ahead.
Yes, sir. Screening of siblings. Hello.
Yes, please go ahead.
Yes, sir. Sir, regarding the genetics and the inheritance pattern, in various systematic reviews conducted by Dr. Stephen et al., the prevalence of VUR was examined in siblings of patients with primary VUR. And the study found that the incidence of VUR among siblings was 27.4%, and among children of affected parent, it was around 35%. Moreover, the risk of VUR decreased among screened family members at an annual resolution rate of 4%. So, additionally, the family prevalence was observed to be lower for more severe form of VUR when compared with the milder form. For instance, the prevalence was around 9% to 10% for grade 3 to 4, while it was 16.7% for grade 1 to 2.
So these are the findings from one of the systemic reviews. Siblings, they had a possibility of 27.4%, and children of affected parents, they had a more occurrence of the reflux to the tune of 36%. And the risk of VUR decrease as the age of a screening family member increase at an estimated annual resolution rate of 4%. As well for the familial rate, lower for more severe compared to the milder forms of reflux, that is grade 3 and grade 4 to the tune of only 9.8% versus grade 1 to 2 is 16. So the higher grade possibility is less as compared to the lower grade. And this has further been authenticated with additional data that in identical twins, 80% prevalence, and fraternal twins to the tune of 35%. But as such, there is no definitive loci or chromosome have been detected to prove its inheritance pattern. So otherwise, this is an autosomal dominant inheritance, and it has been proposed that there may be some polygenetic mechanism affecting the gene regulating development of uterine kidney that might be causing this vesiculated reflux. And these are the various genetic factors which have been studied in regard to that the autosomal pattern. And this is just to summarize it for the postgraduates. They may go through it in more detail. Now, next question is, will you advise screening of siblings?
Sir, he is, I think, he need to be unmuted, sir.
Navneet ji, kindly unmute him.
Yes, sir. The authors concluded that the renal through the various studies, the renal damage progresses in older siblings, which leading to the proposal of early screening for siblings of reflex patients. And the theory which till now what we postulated that there are multiple mutations in ureteric budding and positioning. There is a heightened risk of developing urinary obstruction, VUR, and potentially hydronephrosis. While some cases demonstrate autosomal dominant inheritance mostly, rest of the familial inheritance pattern we don't know. AU and EUA recommended that renal bladder ultrasound in non-toilet trained siblings, but and only performing a BCG in the presence of imaging abnormality. In toilet trained older VUR sibling, there is no use, we can say, because incidence is very low and it is mostly discouraged.
So these are the goals which have been mentioned in the literature to identify clinically unapparent VUR in order to initiate preventive therapy. And the rationale was that the continuous antibiotic prophylaxis may prevent febrile UTI and subsequent renal damage. While this has a limitations as in terms of uncertainty of any potential benefit gained by identifying insignificant VUR. So ultimately the summary of these various studies is that you have to take the families into confidence before going for screening, and in non-toilet trained renal bladder ultrasonography is to be done. If it is showing any abnormality, then one may go for VCUG, while in toilet trained older VUR siblings, this screening is discouraged. Dr. Simona, how do you take these thoughts?
When we started talking about genetics in reflux, I think there was a kind of panicking, and we were screening everyone, every siblings. I think that literature has shown that asymptomatic siblings, just even if they have reflux, it's of low grade and with no scars. And if the SIBs are symptomatic, they could have high grade and scarring. So I think that one has just to offer parents the chance of doing a ultrasonography and the siblings, mostly if they are below 2 years. Then we should not be aggressive unless the child is symptomatic. So I would just offer the ultrasonography if they want. But even if there is a minor dilatation and the child is asymptomatic, I wouldn't go not for continuous prophylaxis and not for the BCG. Just follow up. If the child is symptomatic, then I will just treat him like any other child and go for the BCG. But if he's not symptomatic, then I would be a very, very, very high threshold for doing BCG.
Dr. Walid?
It depends on the age of the sibling. I think the age of the sibling makes a huge difference for me. So say I have a patient who just got diagnosed with reflux and his or her sibling is old and there's no history of urinary tract infection, I will only do an ultrasound. If there was a history of recurrent urinary tract infection, I may do a DMSA actually. But if the patient is young and has an older sibling with reflux, I will do only, again, an ultrasound and I will go through the prenatal history. So again, I think it's really dependent on age of the sibling and also family history of renal issues, particularly when there is a family history from mom's side, which I don't know if you have seen this in Europe or in India. Sometimes moms would say that they used to have recurrent urinary tract infection and they used to have reflux. In those patients, I'm a bit more lower threshold to consider doing more imaging. But I don't do it across the board on everyone. I really go by the age of the patient, the history, clinical history, and I start very little imaging compared to aggressive imaging with history of UTI.
Thank you. So we come to this the conclusion of this session now, and these are some of the publications and which might be useful to the postgraduates. And I thank all the faculty who have graced this symposium on vesicular reflux, and really thank Dr. Walid. And this would have been a early morning there, and we have to disturb you in that early part of the morning. We are really thankful, and I personally enjoyed and the kind of inputs. Yes, and
thank you so much.
Yes, and I also thank Dr. Simona for for joining, and we have been troubling you for many times, communicating and sending you different part of these communications on various occasions also, and I really thank both of you.
Thank you so much.
Thank you so much for the invitation. It was a great pleasure to be here.
And, likewise, and happy holidays. Enjoy your Christmas event today.
Yeah.
Thank you, and the same for both of you also.
Thank you, Priyank, for the invite, and Dr. Ansari.
Thank you.
Bye.
Thank you, Dr. Ansari. Thank you to all the participants. It was a pleasure to be with you.
Likewise, Simona.
Thank you, Walid. Bye-bye.
Bye.
And Priyank, you want to say something? Priyank? Unmute yourself.
Thank you, Dr. Ansari. I really appreciate
Dr. Simona, Priyank is my colleague, and he had been in sick kit for last 2 years for his pediatric fellowship.
Good.
And yes, I hope that he will put his foot into Dr. Wali's shoe soon.
Yes, unfortunately, by the time I went to Sikki's, Dr. Farhat had already left. But it's good to stay connected. I've been in touch with him, and I really thank him for accepting the invitation and accepting this early in the morning. I'm sorry for the confusion that led to this entry in the calendar that really confused us. But I really appreciate you read my email and immediately joined. And thank you so much for your words that actually enlightened us today. And Dr. Simon, thank you to as well.
Thank you.
Yeah, thank
you.
you.
Likewise, I actually enjoyed this meeting very well.
Yes, Dr. Sardar. Yes.
Yeah, sorry, we have to leave early. We are in a car, in a taxi to the conference, and there's a lot of background noise, so we couldn't talk, but we enjoyed listening to the discussion, the last 15, 20 minutes. Thank you for involving us as well.
Well, we came to know that all of you are going to a grand dinner.
Yeah, we are. We are in the cab now.
Yes. Thank you so much.
Enjoy, guys. Thank you so much. It was great meeting. Seeing you, Simona, and seeing all of you.
Thank you. Thanks a lot.
Priyank, good seeing you.
Dr. Walid, Dr. Sardar, Dr. Mohan too. Yes. Thank you.
Bye-bye.
Bye.
Dr. Ansari, thanks a lot. It was a great pleasure.
Well, thank you so much, Dr. Simona. It was really a pleasure and honor.
I hope that I could be useful somehow, and
So I will give you the feedback. This will
thank
be going.
May I just ask you also if you can give me a contact of Dr. Walid?
Oh, yes, I will share.
Thank you.
Thank you.
And thanks a lot. It was a great pleasure.
Well, thank you so much again.